Hello, everybody. Thanks for joining this NoFast webinar. My name is Andy Katcher, the Communications Director at NoFast, the National Organization on Fetal Alcohol Syndrome. And today's webinar is titled Nurses Expanding Roles in Diagnosis of and Treatment of Children and Families with FASD, and will be presented by Lynn Cole at the University of Rochester Medical Center School of Medicine and Dentistry. And I'd just like to invite everyone, if you're not already, to please connect with NoFast on our social media and our weekly roundup email newsletter. You can find that by going to our website at nofast.org. And there's a link to sign up to the email newsletter, which comes out every Monday, as well as links to follow us on Twitter and Facebook and so on. So I'm just going to give a brief introduction of the presenter, and then my colleague Kathy Mitchell, NoFast Vice President Spokesperson, I think is also going to give a few words before we turn it over to Lynn to present today's webinar. Also just want to remind everyone that you're very welcome to type your questions in at any time. The earlier you get your questions in, the more likely we'll have time to get them answered by the presenter. So when the presenter's finished, I'll then come back on and read aloud the questions that were submitted. So also the webinar is being recorded, and a video recording of the webinar will be available within 24 hours on the NoFast website at nofast.org under the button link for webinars. There'll be a link to view the webinar recording on the NoFast YouTube channel. Also, the presenter has agreed to make the individual slides available, so a PDF of those slides will be posted within 24 hours on the NoFast website as well. So, Lynn Cole is a pediatric nurse practitioner who specializes in the care of children with complex developmental and behavioral challenges, and she has particular expertise in adoption and foster care, fetal alcohol spectrum disorders, autism, intellectual disability, cerebral palsy, and the health and behavioral challenges these children experience. And Ms. Cole works at the University of Rochester as the Director of Clinical Services in the Division of Developmental and Behavioral Pediatrics, is the co-director of the FASD Diagnostic and Treatment Program, and she teaches undergraduate and graduate nursing students about child development and diagnosis and treatment of children with FASD and other developmental disorders. So at this time, I'm going to turn it over to NoFast Vice President Spokesperson Kathy Mitchell to add a few words.
Good afternoon, everybody. This is Kathy Mitchell, and I am absolutely delighted that Lynn Cole has agreed to share her expertise and her valuable time with us today to talk about the role of nurses in both diagnosis and treatment of FASD. You know, Lynn and I had the very fortunate experience of sharing a cab in Vancouver on the way to the FASD conference with Lynn last year. And I was so impressed and thrilled to hear that she has diagnosed children with FASDs and is very involved in the treatment and also working with the moms. So I just think, we've thought for so long at NoFast that nurses played such an important role in both prevention and diagnosis and treatment, of course, in FASD. And I was just thrilled I had never met a nurse practitioner who had told me that they had actually diagnosed children with an FASD. So we're thrilled to have you, Lynn. I thank you so much. I hope that many other nurse practitioners hear your experience and move forward and becoming very active in a role in preventing and diagnosing and treating FASD. So with that, I will turn it over to Lynn. Thank you again.
Well, thank you so much, Kathy. It was such a funny thing to ride on the same plane with you and then to catch a cab with you to the conference that it was a great opportunity to connect, and I'm completely happy to be able to talk to everybody today. As everybody said, I'm a pediatric nurse practitioner. I'm at the University of Rochester, which is in upstate New York. And I work in an area, a subspecialty in pediatrics called developmental and behavioral pediatrics. My background is, before doing work in FASD, was initially in working with children with cerebral palsy, and then I've worked for many years with children with autism spectrum disorders, with both a clinical and a research focus, looking at things like how do we standardize diagnosis, how do we standardize the medical care we give to children, are we screening for the right medical conditions, and then also looking at what is the NP, the nurse practitioner role in the care of children with autism. So when I came to know more about FASD, I've been I've really had a great time. And so the person who really provided me the biggest introduction to FASD, you heard from a month or maybe 2 ago from Christy Petrenko. So I'll talk a little bit more about how we came to develop services here in Rochester. I thought I would start, whoops, for some reason this doesn't want to forward. Let's see. There we go. So I thought I would just start a little bit with a background of nurses and nursing in the United States. And so this was actually a good refresher for me, because if you had asked me a couple weeks ago how many nurses are there in the United States, I wouldn't have been able to tell you. So I'll tell you now that there's about, as of 2011, there was over 3 million registered nurses in the United States. It's a rapidly growing workforce, particularly with changes in healthcare that are focusing much more on prevention, community health work, systems of care. So, you know, even with the 3.1 million, that gives us about 1 nurse for every 100 people in the US. About 13% of those nurses hold master's or doctoral degrees, and we have about 10 nurses for every 3 physicians. We'll talk a little bit more about numbers of nurse practitioners and the difference in scope of practice for nurses and nurse practitioners, but just in a comparison in terms of data, you know, one of the subspecialties that we rely a lot on for a diagnosis of FASD is geneticists. And the most recent statistic I could find on geneticists is that there's less than 600 total in the United States. So if we think that we're going to expand diagnostic capacity using geneticists, we are really fighting an uphill battle. So I like to look at nurses as professionals who are available in a wide variety of settings and who really have some unique contributions, particularly to people with chronic illnesses or disorders, things that continue throughout the lifespan and affect, you know, an infant, a child, and a family, that nursing can be a really important contribution to those groups of people. When I think about the unique contributions of nursing to you know, to FASD, but also to other areas of health as well, I think on a number of things. One is that nurses really have a unique focus on family systems. So the training of nurses is very different than the training of physicians or other health professionals. And there's really a focus in nursing on the health and well-being of the whole family. So knowing that the health and well-being of one member really affects the whole family. So whether that is one person who is struggling with addiction, or whether that is one person who has an FASD, that affects the whole family bidirectionally. And so really having a nurse who can focus on how these things impact the whole family system is really important. Nurses also focus on health maintenance and promotion. So whether that is working with women who are at risk for a pregnancy with alcohol exposure, and thinking about how health might be able to be addressed prior to pregnancy, or about how contraception might be used, or whether it is working with a young person or an adult with FASD and helping that person to be as healthy as possible, that's really something that nurses really focus a lot on. Nurse training and nurses in general spend a lot of time on patient education and are very versed in team-based care. So if you think of both a young woman with addiction who really requires a team-based model of care to address both the addiction and the associated physical and mental health issues, or whether you're thinking of a child who, or an adult for that matter, who has FASD, there really is needed to be a system of care. And so relying on, just a physician or just a teacher or any of those things are not going to be very effective. And so nurses are really used to team-based care and are used to organizing teams and helping people collaborate. A big focus, particularly of nurse practitioner education, but also of RN education, is figuring out where there are unmet health needs. So who is not getting the health services that are needed? People who are getting health services that are needed, what are the parts of health that we're not addressing? The other contribution of nursing that I think is very important is that nurses are present in almost any setting that you can think of. And so if you think of the settings that a young woman who might become pregnant or who might be struggling with addiction is likely to be, or whether you think about a young person who is in need of diagnostic care or who is struggling in some other way, these are the types of settings that that a nurse is likely to be present at. So in the workplace, in insurance companies, in private practices, public health agencies, schools, home cares, all of those things are places where nurses are likely to be seen. So thinking about maternity care, nursing education, mental health agencies, even jails when women are incarcerated, these are all places that nurses are likely to be. So nurses are likely to frequently come in contact with both adults and young people. So nurse practitioners. Nurse practitioners are professionals who have completed an undergraduate education and have certification as a registered nurse, and who go on for additional either master's or doctoral degree preparation. Nurse practitioners are licensed by the state in which they practice, and they're licensed through a national organization. There's 2 national organizations that credential nurse practitioners. There's a large variety of specializations that nurse practitioners may have, but I listed a few that are likely to be pertinent to the care of people affected by FASD, including pediatric and adult primary care, as well as family health, women's health, psychiatric mental health care, certified nurse midwives, and acute care. And I think, particularly if you look at nurse practitioners in women's health and nurse practitioners who are certified nurse midwives, they are very focused on health promotion and prevention of complications. And so thinking about directing FASD prevention to those nursing groups is likely to be very effective. The other thing I have to say about nurses is that nurses are much more, at least this is my personal experience, so I don't want to generalize, but in my experience, nurses address the psychosocial contributors to health very directly. So nurses are not generally ones to beat around the bush if they have concerns about risks to a woman's safety, to a woman's health, to a child's to a child's safety or health. And so some of the issues that I think that we see in families who have someone affected by FASD is that there's a lot of elephants in the room. And so having a nurse practitioner who can address those directly is very helpful. So I wanted to talk a little bit about what is the scope of practice of nurse practitioners. So in each state, this is going to be slightly different, although there's some commonalities. So just like RN practice and MD practice and teacher certification in different states, that the specific scope of practice is designated by the state itself. But in general, the nurse practitioner scope of practice includes assessment, diagnosis, and treatment of acute illness and injury, as well as management of chronic illness. And we'll talk a little bit about the unique contributions of nurse practitioners, but I think that the management of chronic illness or chronic disorders is a really important focus for nurse practitioners. Nurse practitioners prescribe medications and other treatments, including DEA-controlled substances. Nurse practitioners order, perform, and interpret diagnostic tests. So not that much is really needed. So lab work and that kind of thing is not really needed for an FASD diagnosis, but nurse practitioners with training can be able to interpret, for example, the psychoeducational testing that might be used to make a diagnosis. Nurse practitioners are very skilled at managing patients' overall care. Those, especially in the mental health area, who have specific credentialing, may provide individual therapy, group therapy, and counseling. Depending on the state and the specific licensure in the state, some nurse practitioners do run independent practices that do not have a practice agreement with a physician. So that varies state by state. So if we look at NPs and what they do, we think as of 2012, there was about 127,000 nurse practitioners. About half of those are working in primary care. So again, if we compare nurse practitioners to geneticists, there is many-fold more nurse practitioners who are available to do this type of work. Nurse practitioners are graduating at a pretty rapid rate. In Rochester, I know that our School of Nursing cannot graduate nurse practitioners fast enough to fill all the positions. One of my colleagues, actually my boss, is in charge of hiring all of the nurse practitioners for the hospital. Our hospital system, I think, has about somewhere between 900 and 1,000 nurse practitioners at University of Rochester Medical Center, and she has more openings than she can fill. About close to 90% are nurse practitioners who are certified in an area of primary care, and about half of nurse practitioners practice in primary care. And if you look at the data around the why nurse practitioners in primary care are so important, there's a number of reasons. So nurse practitioners are much more likely than primary care physicians to practice in underserved settings. So that includes urban settings, rural settings, settings where there's uninsured patients, and treating other vulnerable populations. About 75% of nurse practitioners are in a practice that accepts Medicaid, which is also quite different from generally if you look at the data on physicians. And nurse practitioners, I think, really have a unique contribution and an approach in both their approach and in their training that I think has the potential to be quite useful in working with families affected by a person with FASD. So nurse practitioner training and really the professional culture has an emphasis on a couple of different areas. There's really a lot of focus on the diagnosis and management of chronic conditions. So whether it is diabetes or ADHD or asthma, all nurse practitioner programs really focus a lot on chronic conditions. And although developmental disorders like FASD aren't always perceived as or thought of as a chronic condition, my philosophy on caring for children with developmental disorders is very much that this is a chronic condition. This is something that is going to be present across somebody's lifetime. It is going to look different at different ages. Different symptoms may get better or may get worse, and that families really benefit from anticipatory guidance, knowing what to expect, being educated about the condition and knowing what to do, and those are all areas that are very consistent with nurse practitioner training. Nurse practitioner training also has a strong focus on the psychosocial contributors to illness. So if we think of things like addiction, poverty, trauma, mental illness, all of those things really have a strong contributor to both your physical and your mental health. And that's a big focus of nurse practitioner culture and of the training programs. Programs also focus a lot, like I've spoken on health promotion and maintenance, on family systems, and on care for underserved populations. So let me talk a little bit about our Rochester experience. So I started at the beginning. So in 2013, I was working here in developmental and behavioral pediatrics, and Christy Petrenko was working up the street in one of our associated programs called Mount Hope Family Center. And she came and did a fabulous pediatric grand rounds on fetal alcohol spectrum disorders. And it was a topic that I knew something about, but not a ton. And I listened to her talk and I thought, sheesh, we really ought to be doing something about this. I can't believe that we haven't had a bigger focus on this in our division. To this point, there had been a geneticist in Buffalo, which is about an hour and a half away from us, who I knew had been doing some diagnosis, and I really didn't know where other kids were going. So I popped Christy an email, and we decided to get together, and we met at Starbucks, and we had coffee, and we decided we were going to set up a clinic. And so the stuff I like to do is really around organizing systems of care. And so we just kind of figured out how to make it happen. And it was a lot of trial and error. I started out, I needed to do some training myself. I came from a little bit of a different background than many other primary care or many other nurse practitioners might come with, in terms of I had some pretty good background in child development in general and general principles of child behavior, but I needed some specific stuff. So I really needed training on physical measurements and dysmorphology, which there's a lot of good stuff available online. So I did a fair amount of online training. I worked with Christy and with Luther Robinson, who is the geneticist in Buffalo, and established inter-rater reliability. I did some self-training in terms of learning the behavioral symptoms and management, and then I got a lot of individual mentoring from Christy and from others regarding things like executive functioning, behavioral supports, and other treatments. And I have gone to a couple conferences, and so this was kind of an unusual system of learning the skills in this area, but we made it work. And so then I tried to talk through the progression of the care model. I think I updated my slides last night, but these are showing up the old ones. But anyway, so we started in about 2013. When we piloted this, we were seeing about 1 patient per month. Our first several patients, it took us several visits to get through the neuropsych testing and the physical exam and the feedback to the parents. We were not very efficient, but with time, we were able to streamline our visits. We moved up to 2 patients per month. We really started to standardize our approach to care, and we decided that we needed an objective system to make a diagnosis so that we had a high degree of inter-rater reliability, and so we started using the 4-digit code at that time. We created some templates in our electronic medical record that helped to streamline some of the report writing and some of the feedback to families. And by 2015, we had already exceeded our capacity with doing 2 evals per month by a significant amount. And so we made a decision at that point that that the younger kids were really not necessarily benefiting from neuropsych testing. That in New York, we have a fairly good early intervention and preschool program, so that most children were receiving adequate both behavioral and developmental evaluations in multiple domains. And that's the model that we use for all of our other developmental clinics, so that we really do very little specific like psychological or speech language testing here at our center, that we rely on school systems to do those. So we switched to the same thing, and we maintained the interdisciplinary evals 2 per month for the children who are between 7 and 17. And we shifted to a nurse practitioner only led diagnostic clinic for the children who were under 6. I was also doing consultations in our local county's foster care pediatrics clinic, and so I was also doing about 2 evals per month in that clinic. I also started following some of the younger children who weren't receiving psychiatric care for ongoing care and medication management. We continued to expand, and in 2016, when the IOM criteria came out, or the refinement of the IOM criteria, we switched to the IOM criteria for diagnosis. We continued doing 2 interdisciplinary evals per month, and those, again, we were beginning to use more trainees, trying to expand capacity, both of psychologist trainees and nurse practitioner trainees. I continued doing 2 foster care evals per month, and I was seeing about 6 patients per month in just an NP model in clinic. That also was, we were running short on capacity. Word had started to get out, and so I trained one of our fellows, our developmental and behavioral pediatrics fellows, in FASD diagnosis, and she began seeing patients at a rate of about 4 per month. She and I together began mentoring our physician and nurse practitioner team here, which is about 4 additional MDs and 4 NPs. We also, at the end of 2016 or beginning of 2017, we initiated some training of an adult nurse practitioner and an adult physician to try to expand capacity for adult evals. And during the course of that year, I also mentored a psychiatric nurse practitioner who was interested in this area. By 2017, we are now up to, we're continuing at the 2 interdisciplinary evals per month. I'm doing about 9 evaluations per month of new patient evals for those children who are either under 7 years of age or occasionally for some older kids who already have diagnostic testing that shows enough in the area of deficits to make a diagnosis. So if a child on their school testing has enough deficit to meet FASD criteria, we are not generally using up our neuropsych testing slots for those kids. Our MD continues to do about 4 evals per month, and we will be starting this fall adding an additional 2 slots per month for neuropsych testing alone. So for those kids who either the risk for an FASD was not apparent when they came in for their initial visit, or for some reason they only saw a medical provider and they need to come back for additional neuropsych testing, we are making that available. In addition, we're working more on refining insurance billing for those kinds of things. We have done a fair amount of work in broadening the reach. So Christy and I fairly early on recognized that there's a large population of kids and families who need support and services, and that probably the 2 of us couldn't do it on our own. So we have done a number of things. We, a couple of years ago, started a family night. So it's an opportunity, for us to do some training of some undergraduates who are our volunteers for family night. We run this once a month group where any family with a child who is diagnosed is welcome to come. The parents or caregivers meet in one room and kind of cover a topic, and we run smaller group activities for multiple kids of different ages in other rooms. Typically we have had, well, so I think our last session this year we had maybe 25 parents and 30 or 35 kids. In general, our family night has primarily included foster and adoptive parents, as well as family caregivers. So we've had a couple biologic fathers, some grandmothers, some aunts and uncles. We're really encouraging people to bring other family members who are part of the care of the child, so that there can be a broader group of people who understand how FASD affects learning and behavior, who can support the family and the child. You know, I didn't mention earlier, so I'll go back to this about working with birth mothers. So let me just run through this. The family did very early on that they wanted to have a way to connect with each other between family night sessions. And so one of the families has started a Facebook page. I think that now there are probably 60 or so people on the Facebook page. It's mostly family members. Christy and I are also a part of it, and there's a couple other professionals. We occasionally post resources or answer questions, but primarily this is an opportunity for families to share resources, share local community events that may be helpful, and finally to do a lot of problem solving. Easily within the last week or 2, 4 or 5 families have posted, gosh, I'm really struggling with X. And so and generally 4, 5, 6 families respond with ideas or moral support or resources. And so it's been a really nice opportunity for families to connect with each other, to have somebody who feels like they understand what this is, what the experience of having a child with FASD is like, and who can provide some supported problem solving. Another way that we have expanded the reach is that Christy has been running a Families Moving Forward intervention program initially through her research project, and we're transitioning that to a clinically run program that will be billed through insurance. And I don't know the exact number of people that has reached so far, but I would say easily 15 or so families. And so it's been really nice because as families have had these conversations on Facebook, I can see some of the training points or the reframing from families moving forward coming into their suggestions for the other families. So people are helping each other with that kind of reframing, and it's been really, really wonderful to see. We have partnered with another community agency who is providing education to school teams, which has been one of the most helpful things for our kids in terms of school success, that when their school, you know, as you all know, this is not news to any of you, but that when school teams really feel like they understand the child, and when we can help them understand that this is a brain-based disorder, school goes much better. We have recently engaged with an adult neuropsychologist and 2 adult providers, a physician and a nurse practitioner, who are interested in diagnosis of adults. And so we're trying to support having some capacity for that in our community, because currently there's nothing. And finally, we're continuing the training of the developmental behavioral pediatrics physician and nurse practitioner teams. Back to the topic of birth mothers. So I've had, I've been really lucky in being able to work with both caregivers who are not the child's biologic caregivers, as well as a number of birth families. The majority of birth families that I have encountered have been through my work in foster care pediatrics. So my experience has been is that when a mother who has struggled with addiction most often has children removed from her related to her addiction, but then is really in recovery and is working hard to get her children back, moms are looking for help. And so I've really had some amazing opportunities to work with birth mothers who have been able to be honest about their life and their struggles, and who really want to do the best thing for their child. And I think that this has been really helpful. I know that there is a huge amount of shame and wishing things were different. But I think these moms all want to move ahead, and if they're going to be successful in parenting their child, they need supports. And so the kids that they have are not easy kids to parent. And so they need the supports that are available to non-parental caregivers. And so once we've been able to work through that, these families have been really amazing. One biologic mom was also able to go through the Families Moving Forward program, and I think that really assisted her in the process of reunification with her child, which was really an amazing thing to see. So, so we've been really lucky with that. I also work with a number of biologic fathers who the biologic mother is not currently in the picture, but I think being a biologic father of a child with FASD also has its own set of challenges, and so that's also been an interesting group to work with. Challenges, I just listed a few, but I think there are probably many more. In New York, there are certain New York State departments, particularly the departments related to adoption and disability services, who like a physician's or a PhD signature for diagnostic reports and in terms of qualification. I've been able to collaborate with my collaborating physicians and make that happen, but I know that that can be a challenge for some people. Creating time for practicing nurse practitioners to receive training and mentoring is also a challenge. Very few people in practice are able to just take a day or a week or a month off to learn this. They have to kind of fit it in between all of their other responsibilities and their required patient visits. And so fitting in that time can also be a challenge. Some of the other challenges that I didn't list is that I actually think for me, learning the FASD diagnostic algorithm was the easy part. That the more challenging parts are learning the context to put that diagnosis in. So learning about addiction, how addiction works, how it affects families, multi-generational addiction issues is a huge part of this. Understanding things like the foster care and adoption system and how that works, understanding kinship care and how that works, understanding the mental health system and how to get the right level of services and supports for kids. And finally, understanding the impact of trauma and neglect and how that looks, similar, different in how that looks in combination with FASD. So, thinking about training issues is, there's more to it than just the diagnostic algorithm. That's actually the easy part. So in wrap up, both RNs and nurse practitioners, there's a lot of them. They're a growing part of the healthcare workforce, and we should be paying attention to that. Both RNs and nurse practitioners are in the places where children and adults with FASD are, and they're also in the places where women who are either currently pregnant or at risk of becoming pregnant are as well. And so we need to utilize them for that. Finally, nurse practitioners have a unique training background and approach to care that really may help to meet some of the unmet needs for people with FASD, both in terms of diagnosis, treatment, community education, and really understanding this group of kids and how we can support them, kids and adults. So with that, thank you. And I like to be informal, so I'm happy to have questions.
All right, thanks, Lynn. Much appreciated. This is Andy Catcher again, Communications Director at NOFAS. So yeah, we have some questions, and again, everyone is welcome to type your questions in the little question box, and it'll be asked to the presenter, time permitting. So one question we have is some person wanting to know what year did it start for information on FAS or FASD to be taught to some nurses during their training?
That's a great question. So my guess is that information on FAS and FASD is probably not routinely taught in nursing schools in general. In my institution at University of Rochester, I teach a class on primary care for children with developmental disabilities. And I probably taught it for 10 years ago, and I certainly cover FAS. I would say, until 5 years ago or so, I probably did not cover it very well. I think I cover it better now, but I'm doing one class that's probably 3 hours long, and I'm just covering the pediatric nurse practitioners in our program. And, within that 3 hours, I'm covering FASD and Down syndrome and intellectual disability and autism spectrum disorder and, multiple other developmental disabilities. And so it's probably not adequate. And I don't know what other schools of nursing are teaching. So that's a great question. And I don't know how well it is covered in undergraduate education. There's really not, that I know of anyways, no particular standard on that.
All right, thank you. And we have a question about if you have any advice for a nurse practitioner that doesn't really have FASD-informed physicians or systems in their area, and somebody that would like to diagnose but doesn't have the support. What sort of advice you might have in that situation?
Yeah. So I'm actually, this is one of these areas that I've been pondering recently, particularly since you guys asked me to do this talk. So it's something that I'm going to need to do some more thinking about. I think that, there's excellent information on the NOFAS website. I think it's certainly one of the areas that I learned from. The new IOM guidelines on diagnosis of FASD are fairly they're fairly simple. I like the relative simplicity of them, and so that's helpful. But I really think that in order to do this well, people need a mentor. And so it may be reaching out to whoever is near to you, or I'm also happy to talk to people individually to think about how we could be training nurse practitioners in this, because I think it's doable.
All right, great, thank you. And could you speak to, somebody wanted to know if you could speak to if you feel like there's a taboo against nurse practitioners making an FASD diagnosis, or if there's resistance that you've heard from people?
So that's a really good question. So I am in a little bit of a different position myself, because I have been making diagnoses of different developmental disorders for quite a long time. and it's something that I feel comfortable doing and confident at. I can say that many of the nurse practitioners that I work with have a lower degree of confidence and want to defer to me or to a physician. And so I think that that is an area that we can grow and develop in our nurse practitioners. I think that it requires some mentoring, though. I think people need some mentoring that encourages them to, like, you know, yes, you can do this. This is what, you know, this is how you do it. This is, and, you know, this is the steps in terms of advising families. I don't think it's something people can just jump right into. And like other diagnoses, this is a, you know, an emotional thing for families in terms of hearing news of a difficult diagnosis. In many ways, it's you know, like many other life-altering diagnoses that families may have suspected it, but actually hearing it can be quite challenging. And so it needs to be, the person sharing that diagnosis needs to feel confident and have the communication skills to communicate that effectively, and needs to know what they can help the family to do about it, because it's no good getting a diagnosis if there's nothing you can do about it. But I think that needs to be part of any kind of training program. If we're going to train nurse practitioners to be doing this more often, that they need to gain not only the cognitive skills and how to do the diagnosis. It's almost like this falls into the category of the stuff that's not as easy, is about how do you share difficult information with families, how do you feel confident in your diagnosis, and also having a backup system. So, you know, not every diagnosis is straightforward, and sometimes you need to run it by somebody.
All right, great. Thank you very much. And could you speak a little to the challenges of diagnosing adults versus children, or people along different ages?
Absolutely. And this is something that I would say is in my learning area. So because I only have access to a neuropsychologist who can test, and we only have materials to test up to about age 17, that I have not done a lot of adult diagnosis. I have worked with one young adult who had testing from an outside system. So there are differences in facial measurements, because your facial features change as you go through adolescence and into adulthood, that sometimes can change the appearance of some of the diagnostic facial features. Often the growth features are not as present in an adult as well. So, you know, the physical exam diagnosis can be more challenging. It can also be more challenging to obtain a reliable history about alcohol exposure during pregnancy the older a person gets. And that's, you know, that's just a distance and time thing. Some of the things that I have found helpful in at least aiding diagnosis are when families have photos of the child at a younger age. Sometimes that can help to confirm facial features, although families will tell you it's very difficult to find photos of your child, you know, straight facing the face where the child isn't smiling, because you need facial, you need to be able to do facial, you need to be able to look at the face when the child isn't smiling or making a face. So that can be a challenge. It's very helpful to have growth records, because sometimes growth differences are more notable in the younger years. And that's even a challenge when I see 7 or 8 or 9-year-olds. If they are not with a biologic parent, it may be that nobody has access to birth records or growth charts. So I think those are the primary challenges. It can be also somewhat more challenging to sort out by the time a person is an adult. If they have not had an accurate diagnosis in the past, there may be many more mental health challenges, school difficulties, or workplace difficulties, or involvement with the criminal justice system. And so I know there's a lot of people doing work on adult diagnoses, particularly in the criminal justice system. So I may have to defer to them a little bit, but I think this is certainly an area that people need to be more attentive to. And I think there are nurses who, you know, in those systems of care who could be really helpful in this area.
Thank you. And we have a question from a nurse practitioner doing FASD diagnosis, who asks, what led to your decision to move from 4-digit code to IOM criteria for diagnosis?
That's a good question. I'm glad to hear there's another nurse practitioner out there doing diagnoses. So some of this, I almost wish I had Christy on the call because this was really a joint decision. I think that we felt like the IOM criteria were more widely accepted and supported. The IOM criteria had been out for quite a while, but there was not specific guidance on applying the criteria. So once that guidance on applying the criteria came out, that was appealing. In addition, from a practical standpoint, both in terms of doing the diagnosis myself, as well as particularly in teaching other people, the flow chart for making the diagnosis and the criteria are much simpler and less overwhelming for people. When I was trying to teach my team the 4-digit code, once I started pulling out that book with all of the codes, I think all of their eyes glazed over and they stopped hearing anything that I was saying. So I can say from a training standpoint that the team I work with has been much more receptive to trying to learn diagnosis, which will then expand our capacity since we've been using the IOM criteria.
All right, thank you. And we had a question asking what your process is for referring patients to FASD-informed counselors and therapists.
That's a really good question too, and I wish that we had a better system for that. At this point, in upstate New York, as far as I know, outside of Luther Robinson, who is semi-retired and doing a small volume of diagnoses a couple hours east or west of us, we're the only place that's doing diagnosis in New York State outside of New York City. So it's a pretty wide geographic area, and many of our families come from a distance, from multiple hours away. So, and even in Rochester, I wouldn't say that there is a pool of people who are particularly FASD informed. We certainly, when a family finds a therapist to work with, certainly help them with making sure that the therapist has some background and understanding. That being said, my experience is that therapists who work well with children who have some of the similar past life experiences that our kids have, whether it's past trauma and neglect, work with children with emotional regulation difficulties. Many of them get it, and I suspect many of them are working with children with FASD that they don't realize because that child just hasn't been diagnosed yet. So I have found that most of the therapists that kids I see are working with are quite effective, even though they don't, have a particular kind of credential in FASD.
Great, thank you. And in your experience, do you find that most nurses know there's no safe level of drinking during pregnancy or have that message?
I think nurses are similar to people across the rest of the country, that I don't think that they know that well enough. And I think even within many nursing communities, there is discussion about what is the safe level of drinking. And so I do encounter still a fair amount of resistance to the no safe level of drinking, from nurses, but I would say nurses may be better than some non-nurses, but not always. And I think that's still something that we as a nation need to work on, because it's not out there.
Thank you. And how do you approach diagnosing patients that don't really have any biomarkers?
So by biomarkers, does the person mean facial features or growth features?
Yeah, I think they mean mainly facial features.
Okay. So using the IOM criteria, so if the child is under 3, I use their early intermost. So part of what we ask families to try to do before they come through our evaluation process is, if the child has not already been through evaluation through either the early intervention system or their school district, to get that evaluation done. So the vast majority of the kids we see come with testing. Then we, so in the under 7 group, we utilize that testing to inform the IOM criteria in terms of being 1.5 standard deviations or more below the norm in cognitive, the different areas, so the cognitive areas, executive function or emotional regulation. Many of the children that I see have scores that are more within the average range, which is typical. So the tool that I am currently using in terms of a standardized assessment of executive functioning and behavior regulation is the BRIEF, which is I don't know, it's probably a 60 or so parent questionnaire, and most of the time they're able to complete that while I am doing developmental evaluation and physical exam with the child. And so in our single discipline model, that is what I'm often using if I need additional documentation. In our multidisciplinary model, so the children above 7 all have neuropsych testing, and so we're able to use that cognitive testing, executive functioning, memory, and behavioral regulation testing to apply the IOM criteria.
Great, thank you. And we had a question asking what advice you have in terms of talking to or questioning biological mothers when you suspect or see FASD.
Mm-hmm. So, my approach has been, I really try to speak with the mother in confidence. So if the child is in foster care, separate the mother from the caseworker or from the foster parent, unless it seems to be a particularly amicable relationship and the foster mother or the biologic mother wants her there. And then, for me, the most important part is kind of establishing a level of trust, and that I know you're a good mom. I know you really want the best for your child. And I know that you've gone through some rough things. So, many biologic moms will disclose early on that they have been involved in, violent relationships, or that they were traumatized as a child, or that they've had, rough things in their past. And so I try to establish a level of trust and to be able to be complimentary on the work that I know that they're doing in terms of reunification or doing the best, what's in the best interest of their child. And then I really try to, when I'm meeting with birth moms, start with some of the non-threatening things, like how is your child's health now? How is your child's behavior now? What concerns do you have? And then go back to the prenatal history later on and say, so tell me a little bit more about your pregnancy. And it sounds like that might have been a really hard time in your life. I ask about pregnancy diagnosis. So how far along were you when you found out you were pregnant? What was going on in your life at that time? And so a lot of families, a lot of moms will tell me, oh, I didn't find out I was pregnant until 6 months along, or I was in a really awful relationship and my pregnancy was recognized when I came to the ED because I'd been beaten up by my boyfriend, or things like that. And I think, so I am able to kind of empathize and say, wow, it sounds like that was a really hard time. I wonder, many people, I try to normalize it. Many women who are in circumstances like that will use drugs or alcohol to help them cope with that. I wonder if that was the case for you. And so I really try to kind of talk through that in a non-threatening way. And to validate, like, addiction is addiction is a disease, and I'm not here to judge you for that, but really to just help your child get the help they need. For children who do get that diagnosis, I talk with the biologic mother in confidence about that, and I say, this is what I think is going on, and I want you to help me figure out, who and how to share that. So I'm always very careful. I don't want to have the diagnosis be utilized or perceived as something that contributes to why the birth mother should not have custody of their child. So I try to be very clear in that the diagnosis has to do with the child and the child's symptoms. It has nothing to do with maternal caregiving abilities at this current time. And that can be a struggle sometimes. I've actually had a couple instances with a birth mother and a birth father in the room, where the father is swearing up and down, where they are in the midst of a custody dispute, and the father swears up and down that the mother drank during pregnancy, and the mother swears up and down she did not. And I defer diagnosis in those cases because I don't think that it's appropriate to use the diagnosis to establish child custody. In those types of circumstances anyways. So for the most part, the mothers who I have worked with who are actively working towards reunification, or who really want, I've had other mothers who just come who are like, I really need help with my child because I can't manage this. And when mothers are in recovery, and when mothers are working towards the best needs of their child, that they in general have been okay with disclosing that diagnosis. We do it carefully, and I try to do that thoughtfully. But my experience has been that has gone fine, and has been has been okay for the mother. I don't, not that it's not without guilt or shame or feeling bad about it, but I think that we need a community of people who can be supportive of a mother and the difficulties that she, is having with the child now, or that she's had in the past. So I feel fairly passionate about that.
All right, great, thank you. And we have a couple last questions from parents, and then also my colleague Kathy Mitchell, the Vice President and spokesperson at NoFast, had some closing comments as well. So we had a question from a parent saying that their son now gets SSI and host home services, and that his diagnosis was important for leading to those services, but they found it really expensive to get an FASD diagnosis, and was asking if there's ways to make it more affordable.
That's a good question. I think, I only know about financing here locally in our clinic. One of the challenges is that neuropsychological testing is expensive. It just is. So ways to make it less expensive, so that if a child, the more provider or team can use testing that has been done in the school system, because the testing that's done in the school system is at no cost to the parents, and that can often be enough to inform diagnosis. Not everybody needs neuropsych testing. It's lovely, it's great to have, it can be really helpful in understanding the children's learning, but you need to balance finances with that kind of thing. Most of the medical part of it, I think, is generally covered by insurance, although I'm sure that there are times when families have high copays or high deductibles or that kind of thing. But I know that there's a significant variability in the models of care that different places utilize and the expense associated with that. So it's hard to comment too much on that, but I recognize that that is a barrier. Many insurance companies will not pay for neuropsych testing, except under very certain circumstances. And so there's often a fair amount of advocacy that's required for that. And that may be an expense to the families, but yeah, I recognize that this is a challenge.
All right, great, thank you. And a question from another parent asking that when it came to their child, they found that a lot of the professionals were not very knowledgeable or misinformed sometimes, and that this person is interested in improving the level of knowledge of all professionals regarding FASD. So asking if there are any nurse-geared conferences that have speakers addressing FASD out there?
There are not that I know of. I have, that's on kind of my agenda to think about and to try to do in the future, is to do some of that kind of presenting myself. So, there's an overall several large nurse practitioner organizations that cover all ages. There's a pediatric nurse practitioner organization. There are a number of organizations on maternal and child health nurse practitioner groups, or nurse midwifery. And I think there are opportunities. So anybody who is interested in providing some training, really reach out to those organizations, find out where their national meeting is. I think that all of those nursing organizations could really benefit from this type of knowledge. But there's a lot, there's a lot of nurses out there who need training. So, but it's speaking to the parent perspective. Parent-driven presentations can be very powerful, and having parents submit to some of these national organizations to present would be fabulous. I think there's nothing better than hearing from a parent what your experience is and how we as healthcare providers could be doing better. So that would be an amazing thing.
All right, great. Thank you very much. And we got one last question that came in asking specifically about the CAPTA Act. How do you address the CAPTA Act in regards to newborns with FAS?
Hate to say that I don't know. I'm not sure I know what the CAPTA Act is.
Okay, I think Kathy Mitchell may have some more information. I'm going to unmute Kathy. Would you like to join in?
Hi, Lynn and Andy. This is Kathy Mitchell. That was a fantastic webinar. Thank you so much, Lynn. The CAPTA Act is, boy, I'm not really the person to talk about it, and I don't have it right in front of me, but I do know that the CAPTA Act is a federal requirement that newborns that are exposed to drugs, that they are connected to child welfare or child protective services. And a few years ago, they included newborns with an FASD that there would be a connection to, they don't use the word report. I wish I had it in front of me to speak to this, but they actually require that a connection be made to child protective services now. And again, the intent was to protect not only children exposed to drugs, but also to alcohol.
Okay. Thank you. I guess I would have to know more about it to know the specifics. I always have concerns whenever anybody brings up the idea of reporting or penalizing or any of those things, kind of pregnant women or new mothers, because I worry that forces people into hiding their addiction or hiding what has happened, as opposed to getting the support that's needed. So I guess I would defer on too much comment on it without knowing the details of it. In general, it's very difficult to make a diagnosis of FAS in a newborn without a disclosure of alcohol use, because at newborn, it would be very difficult to have sufficient developmental delay. So even with facial features and growth features, you need to have some evidence of developmental delay. And, if you're newborn, we don't really expect you to do much. So I worry about anything that discourages, while I do want mothers and babies to have the supports they need, I worry about doing it in the right way so that it supports mothers getting the support they need and doesn't force them to hide.
Well stated. We couldn't agree with that idea as well. I think it's really challenging. Let me just say, Lynn, your wrap-up points are so it's so obvious the role that nurses and nurse practitioners can play in helping to fill in the gaps. I mean, there are a lot more nurses out there than there are physicians, and they do work with adults and with children with FASD, as well as with mothers, with high-risk moms, certainly. And, the more we can get the information out there, I think that we can really improve things for families and individuals living with FASDs. I really wanted to just underscore how much I appreciate you mentioning the importance of understanding addiction, because that's going to improve the dialogue with biological moms and their families, understanding trauma-informed care and the role that plays in child welfare and just the family systems that are affected by addiction and trauma. So again, I thank you for your expertise and your time, and it was just a expertly done webinar. And with that, I'll turn it back over to Andy to close us out.
Okay, thank you, Kathy, and thanks, Lynn, again. And we also we got some questions. Some attendees were asking how they might be able to contact you, Lynn, if you'd like to give any information on that.
If I type in my email address, will that work?
Yeah, or you could say that, say it aloud, or I'll put it on the website as well. Sure, whatever you're comfortable with.
Okay. I'm typing it in right now. It's Lynn, LYNN _COLE at urmc.rochester.edu.
Okay, great. So yeah, we can put that with the recording of the webinar for those interested. So yeah, thank you very much, Lynn. And again, a webinar video recording of this webinar will be available on the NoFast website at nofast.org, as well as the slides. And a reminder to please sign up if you're not already to the NoFast Weekly Roundup and to connect with NoFast on our Facebook and Twitter social media pages. And thank you, everyone, for attending the webinar. And thank you very much, Lynn. Is there anything else you'd like to add in closing?
No, thank you for the opportunity to speak to you all. It was great to have this conversation.
All right. Thank you. Thank you very much.
Thank you.
Bye-bye.
Bye.